And that's my main internal technique, I would say, I use for treatment.
Yeah.
I'll do that rectally. I'll do that vaginally. I'll do that wherever.
Love, 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 love. You're listening to The Pelvic Freak Show
with your hosts, Amanda Neary and Hannah Meyer. Hey, Pelvic Freaks. Welcome back to another episode of The Pelvic Freak Show.
Where you're freaks for us and we're freaks for your pelvis, baby.
Stop. Don't do anything until you look at
my hair.
All right. Yeah, that's what I was going to say.
Yes. Thank you so much.
Hannah got her hair done and now we can all relax.
Now we can all calm down because I won't complain about how I hate my hair anymore. And I'm wearing glasses.
And she has new glasses.
They're fake glasses.
It's giving. Okay, I know you're going to take this the wrong way because it's in a really hot way. Jessica Day.
No, I like it.
Okay, good.
No, I like it a lot.
I wasn't sure if you were like, I don't want to be a school teacher vibe, but like it's hot.
I want to be a hot, sexy school teacher vibe.
Okay.
And that's what I am today.
Yeah,
because we're going to teach you guys things.
It's working.
I'm feeling pretty good. We went for the cherry cola vibe. Mm-hmm. Who knows if this color is going to last? Well, we're going for it.
I'm feeling it won't. Hannah, ever since I met her, she had red in her hair before I met her. She didn't dye it red again, and she complained about having red stuck in her hair probably every week for the first year I knew her, and then would say like, if you have red in your hair, it'll never go away. Finally, the red's gone.
Yeah, and then I dyed it red again.
Then she dyed it red again. So, this will be the next 2 years of our lives.
So I will be complaining forever about how I can't get the red out of my hair. You're welcome.
Pelvic Freaks, we're gonna jump right into it, but before we do that today, if you have been loving the pod, please give us a nice rating. We could really use some more exposure on Spotify and Apple and wherever you listen to podcasts. So if you can leave a nice review, that would be amazing. If it's just a rating, give us 5 stars. And I just learned, if it does not let you leave 5 stars, that means you have already left 5 stars. So don't change your rating to 4 stars, please.
Yeah, don't do that.
Don't do that. Keep it at 5.
Wait, you're also being way too nice. Guys, go pick up your phone right now and go leave us a damn review. Please, we're begging you. We're not desperate, but we're telling you to go leave a review.
Yeah.
It makes a really big difference. And if you love us, that would mean so much. And if you leave a written review, that would be even more amazing. But you can only do that on Apple Podcasts, I think.
Yeah. I do want to banter a little bit before we get into the episode because we're having an extreme cultural moment right now with this Lindsay Clancy trial.
Oh my God, I actually wasn't prepared for you to bring this up, but now I am locked in.
Okay, yeah. I actually just thought to bring it up because I was listening to a podcast on it yesterday. I haven't followed every aspect of the trial, but I've seen like a lot of the stuff on social media and watched some of the testimonials that have popped up on like my For You page. And this is such a cultural moment because we're looking at a case where the defense attorney is putting forth some of the best arguments and evidence for how corrupt and awful the U.S. healthcare system is at treating women's postpartum health conditions. And I just never expected that from a 75-year-old white man.
No, I was blown away.
It's crazy.
Yeah, it is crazy.
It's crazy.
The case itself is trigger warning too. If you are pregnant or postpartum, it can be a very scary case to look into.
Yeah.
But it is bringing a lot of attention to postpartum mental health diagnoses like postpartum OCD, postpartum anxiety, postpartum depression, really common things that we see that are not talked about a lot.
Yeah. And and how severe they really are, right? Mm-hmm. So in the case I was listening to, they had defined postpartum depression and psychosis, and what I learned that I had not known is that in other countries, the UK, for example, if a mother takes her child's life within the first year of its life, she is automatically not put in prison, but put into mental health care.
Whoa.
Because it's assumed that she had postpartum psychosis, because that's how correlated it is with moms who end up killing their children and how severe it is. And in the US, the statistic is that most women that kill their children within a year of their life are incarcerated in long-term prison. So it's just not interesting like in a cool way, but how the US treats these cases versus how other countries consider the mental health stipulations of them.
The cultural shift is interesting.
Yeah. and we're not getting into the conspiracy theories today because the husband, I didn't watch the whole trial. I'm not up to date on all the evidence. Some people think he framed her and he actually did it. And if he did, he has a perfect crime because she was experiencing postpartum mental health illness. I don't know any of that. I don't know any of that stuff. But if it was her and this is what happened, we know how severe this can be. And it's interesting that it's being brought to light.
Yeah, when I was going to the Renaissance Fair yesterday, my friend was on that hour drive, was just giving me all the details on the entire case. It seems like the entire United States is invested in this case right now.
Yeah.
And I'm really interested to keep learning more about it. But you do have to be in the right headspace if you're going to deep dive into it, because I feel like diving into anything with mental health can be really scary. Mm-hmm. But yeah, it's definitely something we need to talk about on the podcast.
Yeah, it's any way you cut it, it's a really heartbreaking case. Like, I don't often listen to true crime and get emotional, but I was like, yeah, you're listening to this story and it's sad no matter what way you look at it. So it is a lot, but I think a lot of people feel really strongly about like the situation and feel really sad about it. And I think it was similar with like the Idaho murders and a lot of people watching that trial. And it is interesting, true crime in 2026, like a lot of people are watching it live.
Yeah.
And I never really anticipated doing that in my lifetime.
No, me neither.
But short form social media has made that possible.
I was just going to say, though, the implication social media has watching this trial is so interesting.
Yeah.
Because you can get so many more perspectives on this.
Mm-hmm. Yeah. And it's not that I don't think people should question things, because you listen to so many true crime cases where like the officials that were investigating or the police officers in charge didn't do their job well, and people ended up finding things out for them and whatnot. But then you read the comments that are very clearly like not taking anything into consideration and just starting conspiracy theories. And so there's just a mixed bag of everything on social media always. So you just have to use a lot of discernment if you're going to look at this case on social media.
Because you get so much information, but it's like, what is the right information?
Right.
But it's crazy because podcasts too will do the same thing where they'll try to kind of live investigate a true crime case. So I listened to one podcast when I was driving back and forth to Kentucky in less than 24 hours. And I'm not bitter about it. It's fine. And it was, what was it? It was a really common one. Your Own Backyard. Have you seen that one?
I haven't seen that one.
It pretty much, this guy like does so great at editing this podcast. Knowing how hard it is to edit a podcast, I'm like, God, this guy is doing so good. But he pretty much gets to the point where he's like live investigating this podcast on his own, and he literally helps solve the crime and get the guy arrested.
Yeah.
It's insane.
It's crazy.
So podcasts are literally doing that now.
Yeah.
So I don't know what podcast you listen to. Do you know what podcast you listen to?
I listened to two. I can't remember the first one. The second one was Scandal. So that was the one that was analyzing Patrick Clancy's testimonial and like the discrepancies in the timeline and all of that. That was still, even today, that was weeks ago. So like that's old information at this point from what people are talking about now on social media. The first one, I truly don't remember, but it was a really nice summary. It was actually from a few years ago when the first news story broke. So it wasn't analyzing any of the actual case. It was just going based off of the facts at the time. Okay, got you. Like giving you the... So like the gist of like any data we knew before the trial started is what that one covered. And yeah, just really, really sad, but a good summary. Yeah. Yeah. And I mean, it literally brought up an important discussion today at the clinic. Hannah, who you guys know and love, one of the Hannahs that we brought on this podcast, but was on for the GLP-1 episode, brought up and was like, with this Lindsay Clancy case, quote unquote, trending right now, everyone is looking into it. I just want to make sure we're being better about doing our postpartum depression screening, because we are some of the first people to see our patients postpartum, immediately postpartum. And, sometimes we even talked about how we're seeing people before 6 weeks postpartum. Yeah. We're having them come back in the clinic as soon as they feel ready. And I'm honestly, if people are ready to come back, at least at 3 weeks, I'm saying, come on in. So we're definitely going to be seeing them sometimes before their doctor, unless sometimes they'll do a 2-week check-in at the doctor, especially for C-sections.
I know that there is a hospital out in the suburbs that does do a mandatory 2-week postpartum depression screening where they have their patients come in and do the depression screening, blood pressure, everything like that. And then that's like their mandatory 2-week check-in. And then they have a 6-week check-in. But Northwestern definitely doesn't do that, or the big hospital systems in the city don't do that. So it did bring up a good conversation at
We're
our
recording at night, guys.
I'm giving it a night, guys. Conversation at our all staff meeting today. And we kind of just were like, okay, yeah, let's talk about like our protocol for this and how to bring this up more in our evals. Like make sure we're actually screening it and not just like if a patient comes in and is like, I don't have kids, it's like, haha, like laughing it off. It's like, let's make sure we're actually asking the questions we need to ask.
Yeah, totally.
And being better on our own part. You PTs out there that are listening to, or OTs, or other health professionals that treat postpartum individuals.
Yes, very important to screen for that.
Yeah, so true.
Yeah, it affects up to 20% of people who deliver. So, you know, it's a huge thing that happens.
And also that it's not just postpartum depression. People think postpartum depression, it can vary.
Yeah.
It can vary.
It could also happen in the paternal parent. Postpartum depression can happen in the non-birthing parent.
Okay.
Yeah.
There we go. See, I didn't even know that, guys. All right. Well, there's our banter for that. If you guys want us to go more into this from our healthcare perspective, let us know.
Yeah.
Cool.
We haven't bantered in a while.
Yeah. You liked that?
I kind of liked that. Did you freaks like it? Let us know. Obviously, that was a loaded banter topic. I kind of just knew it would unpack a whole thing of worms, whatever it's called.
Yeah.
But yeah, sometimes it is nice to just get a little banter in.
Yeah, I think my banter's back. You know why? I pulled a tarot card recently. And I pulled a tarot card recently. It told me to pretty much chill the fuck out.
That's so fair.
So I'm just chilling out.
Also, you're about to go on a 2-week trip, and I really think that's going to change things for you.
Yeah, I think that's why the tarot card said chill out.
Yeah, I think.
Whoa, what was that? Did you hear that?
I think that was my throat.
That was insane.
It was like the water.
That was like a bird.
It was weird.
It sounded like the Twitter noise.
Yeah, I guess that's what that happens.
Maybe you should get into voice acting.
Maybe.
Alongside me.
As I'm losing my voice today. Yeah, I think the refresh, I went to Michigan for 2 days this weekend after like a whole stressful month, and it like totally like helped me.
Yeah.
I just feel like a new person this week.
I'm going to Alaska. I'm going to be like gone, guys.
Yeah.
Like disappeared off the United States, but in the United States still, but in Alaska.
Speaking of which, after today's episode, we are out of office for summer break, guys. So this is actually one of our first formal breaks we've ever taken from podcasting. And I don't know how it took us so long to get here, because every time we tell someone how many episodes we've made in 2 years, they're like, you guys are insane. So we are going to take care of our mental health and give ourselves a little breaky poo. And we're going to take 2 weeks off, and we'll be back ready for you in September. So off the top of my head, I can't think of what dates we're gone.
I do. I can think of the dates. So this episode is dropping today, and then we are going to be on quote unquote summer break for 2 weeks. So we will not have a episode come out on the 3rd, and we will not have an episode come out on the 10th, but we will resume on the 17th, and our plan for that episode is a pelvic freak story time. So we will be filming that, and we're also going to be doing a Q&A episode for the episode after that. So that's going to be our welcome back from our summer break series. And we are not dead and gone for these 2 weeks. We will still be on social media. So if you guys still want to like DM us, chat us, hang out on Instagram, TikTok, then we will be there, or you can comment on this episode still, and we'll be chatting. We just won't be posting episodes for those 2 weeks.
Yeah. Wow. Okay. What was I about to say? Wow.
That sounded like Owen Wilson.
Wow.
He's your comfort person.
I guess.
One of them, right?
I think Jason Segel is my actual comfort person.
Yeah, that's good.
Because like Forgetting Sarah Marshall is my go-to.
That's good.
If I just need a comfy cozy.
But then Vince Vaughn and Owen Wilson are also a good one.
They're also good.
But specifically together.
You know who were two of my... Okay, this is going to go into a whole new banter. We don't have time for that.
Okay. What were you going to say?
I was going to say Ice Princess was a comfort movie.
Oh, no.
And now we've got both of the Ice Princesses have passed away.
Yeah, Michelle Trachtenberg was
last year
part of Buffy the Vampire Slayer. So I know that very well, of course. And then, yeah, Hayden Panettiere was probably one of my first girl crushes ever.
Yeah. And she
Ever.
just came out of bisexual this year.
Yeah,
We really lost a bi icon there.
we did. And we hope she's resting in peace. But that's also bringing up a lot of conversation right now in the media on, honestly, how women are treated in Hollywood.
Yeah.
Which we've talked about. Guys, we've talked about a lot, haven't we? Haven't we, Amanda?
We sure have.
Go back and listen to our rant-episodes, and we'll do more.
Speaking of Chapel Roan, I'm going to see her in October.
Love that. Love that.
I wanted to shift that to something a little lighter.
Okay.
But if more comes to light about Hayden Panettiere and all of that, maybe we'll like be ready to discuss that in September.
Yeah.
Because then
I
we
think
could
so.
even do a whole nother episode about something like that.
For sure. And
I
it's
feel like we've got enough content there.
it's what you freaks want at the end of the day. So you let us know. And if
Totally.
you're like listening to that and you're like, actually, no, I'd like rather die actually, then just chat us and tell us that.
Yeah,
and then
let
we
us
won't do
know,
it.
or like don't listen to it when we post it. I don't know.
Okay, I want to read. Let's turn to a positive light here.
All right.
Because I did get this message the other day and I wanted to read it because it made me so happy the other day. This was July 18th and I'm just not bringing this up. Hey guys, I'm a pelvic floor PT. This is a message we got DM'd. So maybe if you DM us, we'll read it on our podcast. Whoop. Hey guys, I'm a pelvic floor PT in New Jersey and just wanted to tell you that I had a client the other day who told me she does pole and I was like, oh girl, you would love this podcast. She was super excited after hearing the name.
Whoa.
So
I didn't even see that one yet.
I think because I responded before you saw it.
Oh yeah, so true.
Yeah, it's okay. I forgot to tell you. So now I'm telling you now.
Obsessed with that.
That's really good, right?
Yeah, really
Okay.
good.
Well, let's jump into the meat and potatoes of this episode because last week we touched on the end of our episode when we were talking about, oh my God, what were we talking about last week?
We were talking about Lionsgate Portal.
Yes, we were talking about manifesting.
But at the end of the episode, we started answering a question, and halfway through that, we were like, oh, we should just make a whole episode on this.
Halfway through that, we were like, actually, we have a lot to say, and I didn't expect that. So, I mean, of course I should have expected. We can't shut up. You guys know us.
What did you expect from us?
And of course, I lost the. Oh no, I have it.
Not
I'm like, I
again.
lost the message. Okay, so I'm gonna read it again for you guys. Last week, the same question, and then we're gonna go into more detail about some techniques that we do. You'll understand what that means after I read the question. Hi, gals. My name is blank. I'm a new grad PT and also working in public health. I found y'all's podcast 8-ish months ago while I was still in school and I am obsessed. I just listened to the newest episode on internal assessments, wanted to reach out. I definitely utilize internal assessments in my practice and see the immense benefit they have. I've taken some of the APTA courses and have a rotation in public health, but aside from that, I am still very much a newbie. My current assigned mentor at work isn't against internal at all, but she is kind of the type that uses it almost as a last resort. Okay, which is not typically how I like to approach it. Love that. Okay, I know this is a little long-winded, but if y'all have some in-depth internal assessment techniques as well as some internal intervention techniques y'all would like to share on an episode, that would be so helpful. Heart. So thankful to have found y'all.
Hee.
And I love her saying y'all because it brought me back to my roots. I don't say y'all anymore since moving to Chicago.
I say y'all all the time. And
yeah,
I
you do say it more than me.
yeehaw.
And I'm
What the
literally
heck?
from Kentucky and you say it more than me.
And I never said it before this year, maybe. I don't even know. Did we leave that in the episode, what we had answered, or did we just cut it all out?
I don't recall, but let's just answer it from bare bones.
Okay. Bare
Okay.
bones. Okay. I am super happy that this practitioner finds value in internal and treatment assessments. It's easier said than done when you work somewhere where, like they said, like the mentors aren't necessarily against it, but it's not utilized to its fullest extent and it's used more as a last resort. So it's really easy when you're working somewhere like that to get out of the mindset of using it or needing to use it and just say, well, my mentor does this, so I'm going to do this. So I'm really proud of them for even knowing to ask this or wanting to ask this. And I love that you find it valuable.
I agree. And it is hard when you are in a clinic and everyone seems to be doing it this way. You're like, okay, well, that must be the way I should do it then, right? So and it's hard to question that.
Yeah.
And then stray away from the pack.
Totally.
So I agree. I agree with that statement.
Cool. Internal assessment techniques, we can start there because I know we had talked about, what were we even talking about that we were like, oh, the necessity of the internal assessment.
Yes.
Duh, that's where this question came from. So on that episode, we had talked about some of the internal assessment techniques that we do and don't use as often, or, well, you know, I've used all of them in some capacity, right? But there's some that you might be your go-tos, and some that you find really valuable, and some that you're using a little less often. So do we want to start with kind of the cookie cutter assessment you would learn at Herman and Wallace?
Yeah. So you go and you're like, actually, I think I want to be a pelvic health PT because we need more freaks like us out there. Great. I love that for you. And you take a Herman and Wallace course or an APTA course or something like that, and you learn the bare bones internal assessment with pelvic health level 1, whatever you're taking. Neither of us have taken APTA, so we're not 100% sure we're there, but this is Herman and Wallace for sure. And they teach you the PERF assessment, which is PERF. It's an acronym, which Amanda loves.
Yeah, I love them.
She loves acronyms.
I think I even know what this one stands for.
What does it stand for?
Power.
Yes.
Endurance.
Yes.
Repetition. Frequency. I got it.
Good job. Wait. Frequency is not what I say. I say fast twitch.
It's fast twitch.
Well, I say fast twitch for sure. But frequency kind of, because you're like quick flicks. I call them quick flicks.
Yeah, I think it's fast twitch probably.
Like quick on and off Kegels.
Maybe I did learn frequency. I think, you know what? It doesn't matter.
Sometimes
we got the gist.
What you're doing is you're assessing power, which is the strength of the pelvic floor contraction, grade from 0 to 5. And then endurance, how long can you hold that contraction for? Cutting them off at around 10 seconds. And then repetitions, how many reps can they hold that contraction for 10? If they hold for 10 seconds, how many times can they do that? And then F is, I call it fast twitch or quick flicks, where you're doing full contract, relax as quick as you can and seeing how many reps you can get in 10 seconds. That is like the bare bones assessment people will typically do. And I stray away from the PERF more and more as I get into my career, because I find that I am just going to the PERF. I found that I was going to the PERF and thinking, okay, I got to do this. I got to do this. I got to do this. I'm running out of time doing stuff that I'm really not using in order to progress my treatment plan. So I found myself just doing it because that's what I was taught. And I found that I wasn't actually utilizing it to like fully make a plan of care always. Like I will say sometimes like you can assess endurance or whatever, you can find things there, but it's not my like, okay, no matter what, this is going to be something that's going to guide me.
Yeah, agree.
Is that how you feel?
I do. Yes, I have a lot to say about the PERF, because when I first started as a pelvic floor PT, I was using it for everyone because that's what we learn in our assessment. We learn the PERF and then we learn muscle tone, which we'll get to. So between those two, that's what you're doing with all of your patients to get better. And I do remember treating a lot of like chronic tension cases where there wasn't a palpable weakness or something. And I was just doing this PERF assessment and I was like, what is this actually telling me? And it was not aligning with those patients. And so I kind of went fully away from it. And then I trickled it back in specifically with like stress incontinence.
Yeah.
So I'll use it mostly with someone who has a leaking with an increase in intra-abdominal pressure, because sometimes it gets really finicky. The reason you're testing for power endurance, I really should know what it stands for, because all of them like are different things that you're doing. So how many times can you hold it? I think repetition might be my least favorite part of it, but the fast twitch, that makes sense to me. Because if someone's a runner and they're leaking and you're not finding a true strength deficit, maybe it is more of that like quick flick. Maybe it is the endurance associated with that. So in cases like that, sometimes I find it valuable to get the PERF assessment as a baseline. But really, outside of stress incontinence, I'm not using it.
I use it so much with stress and incontinence specifically.
Yeah.
Exactly. And yeah, I mean, a lot of times you are working with tension. If someone can't even do a Kegel, it's kind of hard to keep going through the PERF assessment, right?
Yeah, that was the other thing. Half the people couldn't do a Kegel. And I'm like, I don't want to pretend I'm asking you to hold it if you're not even doing a Kegel correctly.
Exactly.
Your Kegel's a 0.
I feel like that experience that you had just speaks wonders. I feel like so many people have that experience. And then they're still just trying to go through the PERF because they're like, I got to get my objective measures in. Yeah. But there's other objective measures.
Yeah. And it's a good example of like when something doesn't make sense in your toolkit, fully getting rid of it maybe isn't the answer, but it might help you realize like why it was there in the first place.
Maybe taking a step back is the word.
Step back is the right
Analyzing, seeing what you're actually looking for, and then taking what makes sense of it. And it's not even necessarily that I have to do, okay, let me do it step by step, strength, endurance, repetition. Like if you're just want to, let's just see your endurance. How long can you hold this for? Okay, let me see your like quick flicks. Like it doesn't have to be a whole thing. You know what I mean?
Yeah.
But I agree. Like how quickly they lose that contraction can tell you a lot. How quick they, like if they can't fully relax after they do like a quick contraction, that tells you a lot. So like we're still doing the perf to an extent, maybe not just like as structured and by the book as we kind of initially were taught, because now we know what we're looking for.
Yeah.
And now we know why we're assessing these things.
And I think the more you do internal assessments, the perf was probably named that so people wouldn't forget the order of it, right? And it's, you're teaching new people a new thing and you don't want them to forget it, and they have to pass a test and treat their patients. So it makes sense to use it when you're new and you're getting used to it, and then you can really learn which pieces of it you need for your patients. But the question being, what is valuable about internal assessments, like what techniques are you using? I would say if you're treating someone with stress incontinence and you're trying to do it without an internal assessment or internal treatment and you're hitting that wall, that's where something like the perf assessment would really come in handy to understand what aspect of the pelvic floor contracting and having endurance and doing all of that might be missing. And you won't really get that without doing an internal assessment. And with these patients, I would always do an internal assessment at the first appointment. But if you're somewhere where like they're using it as a last resort, that would be when I tap in and say, hey, let's actually get in there and see what's going on.
No, I like that.
Yeah.
What I find myself doing mostly in the first treatment session, I would say first evaluation, initial evaluation, when I'm doing an assessment, because we're talking about assessment stuff right now. I'm mainly assessing for tone, which we learn, like tension of the pelvic floor muscles, muscle restriction, trigger points. If there's pain, starting at the first layer, second layer, third layer, we're kind of looking for trigger points, or maybe if you're wanting them to use a wand potentially or a dilator, like what kind of tension is it? What would they benefit from? More of the dilator route, more of the wand route, doing some more like internal sessions before you decide that, things like that. And then I'm assessing breathing coordination over anything. So I'm teaching them diaphragmatic breathing, looking at their abdomen a lot of the times, and then seeing how their breath control is, or when they take an inhale, what does their pelvic floor do? That tells me, I feel like, the most out of anything.
Totally.
And then trying to coordinate that with like a pelvic floor contraction eventually or something. Like that's what I'm kind of like going towards in my first assessment typically. Because I feel like that gives me such a baseline knowledge of things.
Yeah. And it also tells you, because you can ask a patient to take a diaphragmatic breath and watch them do it. But if you're palpating internally and feeling what's happening in the pelvic floor, you know how the pelvic floor is reacting to that breath. And if it's actually relaxing things, if it's going to the right place, if they're tensing their muscles to contradict that air, you can tell so much from about someone's coordination from doing an internal assessment and assessing their breathing.
Yeah, because what if they're like tensing the crap out of their pelvic floor when they're inhaling? Or maybe their pelvic floor just like isn't moving at all, like nothing's happening, which is what I see a lot. And then using like external cueing, like whether it's like cues to be like, we've talked about cues before, to relax your pelvic floor, you know, like dropping the elevator down, like unclench your butthole, like act like a peeing in the lake, something like that to help relax your pelvic floor as you inhale, and trying to just like get that baseline down like day one. Like, can you relax your pelvic floor when you inhale? Can you feel that? And can I give you that feedback? That's like a lot of the times going to be like good baseline knowledge to start. And then from there, building upon like maybe the perf assessment if you wanted to, strength, analyzing more from there.
Yeah.
But you might not get to that day one, because sometimes that breath coordination takes so much time to work through.
Yeah, for real.
And if it's not like the strength deficit necessarily, and it's more of like the pain or the tension. Okay, cool. Any other assessment, like internal stuff that we want to talk about, specifically internal?
I would say, you know, if your patient is, I'm assuming that in your practice, the person asking this, if someone is coming in with symptoms of like a reflexive issue, like vaginismus, something where the muscles are contracting involuntarily, I'm assuming that's when their mentor would tap in and do an internal assessment. But you really want to assess that stuff internally or even externally, but still doing like a pelvic floor assessment where you're trying to enter the first layer, right? To see how the muscles react. so willing as your patient is comfortable with it. But without that, you're not really getting the full picture of their condition, right?
Yeah.
So like I would need to at least suggest that assessment to feel like I even assess that patient well with
Yes.
what they came in to treat.
I agree, because there are cases when it's like, sometimes I just need to do an internal assessment to see what's going on.
Yeah.
Maybe we don't need internal treatment from there, or maybe we just do it like every few visits just to like re-coordinate breath, pelvic floor. Like sometimes that can be the case, but it being a last resort, then like that like guides my treatment from the beginning. So if I'm using it as a last resort, I feel like, okay, I'm trying all these other things that could be the answer first, but I'm never getting like, it's so easy to just do an internal assessment and see if like that could have taken me down a completely different route.
Right.
And now I'm saving this patient like weeks and weeks of pelvic health PT.
It's still just, no matter what assessment we talk about, it is just the most streamlined way to assess the condition, right? So, and for conditions like a prolapse, like you're really not going to assess that fully without doing an internal assessment. There's things where the light bulb goes off and you're like, yes, of course. But I'm sure that the conditions like low back pain or maybe some hip involvement, you're like, okay, well, is the benefit there for those? And I would argue yes, still.
Yes, definitely.
Always.
Like hip flexor pain, groin pain, like lower abdomen even.
Totally.
Like totally pelvic floor. Assess that pelvic floor, baby.
Oh yeah. 10 times out of 10 over here.
You said something else that I wanted to pounce on like a cat, and I didn't get to it quick enough, and now it's escaped my memory.
Prolapse?
Prolapse, yes, thank you.
I had a feeling that was the only other condition.
External assessments too. Like even if your patient doesn't want to do internal, like postpartum too, if they're not 6 weeks yet and you don't want to go internal, obviously, like external assessment you can still do. Squeeze, bear down. If they're like, I feel like there's this weird skin here, what's going on? Like, can you tell me? I haven't seen my doctor yet.
You're referring to external assessment.
External assessment.
But observation of the pelvic floor.
Observation.
So still undressed under the sheet. So you're observing the pelvic floor externally.
Yes. Yeah. Observation of pelvic floor externally. Because you can do an external assessment like with clothes on. And things. But I'm talking like under the sheet. Watching the pelvic floor Kegel, watching you relax, watching you bear down, things like that.
Yeah.
For sure.
Totally.
Which we learned that as well.
Absolutely.
In our pelvic health level 1, right? And then many other things that you can do dependent on the patient and the case. So
should we get into treatment?
Let's get into treatment stuff of some different techniques you could use for treatment, maybe that I found beneficial, that maybe I didn't even learn in my mentorship, but I found helpful on my own practice and know what works for patients. Okay. I'm going to say it. Rectal treatment. Do freaking rectal treatment.
Yeah.
Do your rectal treatment. It is literally the same thing as like if you're skipping internal vaginal treatment. If you're a pelvic health PT, level 1 is like, I know how to do the internal assessment, but like I use it as last resort, right?
Yeah.
Level 2 is like, okay, I do internal vaginal assessment with all my patients. Yeah. Level like gold standard, in my opinion, is like, I am doing the vaginal assessment for my people with vaginas, but I'm also strongly suggesting that we do a rectal assessment too. So boom, bada bing.
Explain your reasoning.
I just have had so many times where like I get plateaued and stuck with someone where then we finally shift to rectal work, and maybe they didn't have like a bowel thing that like sparked my interest to go to rectal, or they didn't say have tailbone pain, or they didn't have like, I don't know, proctalgia fugax, like butthole spasms or whatever. So I didn't think about it right away. But then we get like 6 or something weeks into treatment, and I'm like, why am I not getting like, you're still having this pain? And then we do rectal, and I'm like, whoa. Yeah. Game changer. And like, then now they're doing like internal rectal work on themselves at home, or using the wand or a dilator, whatever it is. And now their pain's gone. And it's happened so many times now that I suggest it so much sooner. The only reason I say suggest it is because patients are typically a little bit more apprehensive, because if they especially are like, what? Like, I'm not constipated or whatever, then like, why would I need to do? It's kind of like harder to get patients on board. But if you explain about the necessity behind it, people typically get on board, I would say. And it's not like you're forcing them. It's the same thing with internal vaginal assessment, right? It's like you're just explaining the facts, saying like, I strongly think this would be beneficial for you, even if we just assess it, right? And then maybe we don't do it again if we don't find anything. But what's the harm in assessing it and saving you weeks and weeks and weeks of for example, por ejemplo, chronic pain that you're in.
Mm-hmm. And I wanted you to explain that because I think a new pelvic floor therapist listening to this would be like, whoa, whoa, whoa. No one told me I have to do rectal with all my patients. It's important. And it's important to have the skill set, even if you're not using it with all your patients. Why? Because we know all of the pelvic floor muscles attach onto the tailbone. What entry is closer to the tailbone?
Yeah.
You're literally getting closer to the insertion of the muscle of the pelvic floor. So if you're working on a tissue release, if you're working on the tissue itself, doing any form of massage on the pelvic floor muscles, I'm getting into treatment because you kind of covered assessment, working closer to, as close to possible as, oh my God, I can't speak
I guess
English.
I did do more assessment stuff with introducing rectal.
It's okay. I can't speak English tonight.
You want to go into treatment, Hannah? Yes. Assess rectally.
Assess rectally.
That's not treatment, but it can be.
We're gonna get into like treatment techniques in a second, but I think it was important to address that because we didn't really talk about it in the assessment piece, and that is important. As close as possible to the insertion of the muscle, it's going to give you the best release on it, right? And we know that. And we're not saying like you're physically lengthening the muscle, but you're also working on the nervous system with all of that, which is what we're going to talk about with our internal treatment tools.
True, because I feel like with rectal work, you get people to relax more.
Yeah.
Because what does your butthole do when it feels poop in it? It relaxes.
Yeah. Also, there's a rise in colorectal cancer in young people to an extent we've never seen before. There's a rise in IBS, all of these symptoms. Why? Because everyone's stressed, because society's stressful, because the world is stressful. Mm-hmm. Your patient likely has some rectal stuff going on, even if it's not like the primary complaint that they came in for. So if you're justifying it by saying, hey, this is our most comprehensive way to assess your pelvic floor muscles closest to their insertion point, and then you end up finding something valuable that you can apply to their treatment, if it ends up just being an assessment, great, but you might end up using it for treatment too.
Oh, yeah, definitely. Mm-hmm. Oh, definitely. Sometimes it's we're not even doing vaginal anymore. We're doing rectal work because like this is what's making everything better.
Also, if your patient comes in with tailbone pain, please do the rectal assessment. That's like a no-brainer, and they will feel like night and day if you do internal rectal treatment on them.
Yes, my dude.
Yes.
Yes, my dog. Mm-hmm. It's not just glutes at that point. You got to go in. That's the closest you can get to the tailbone.
Yeah, that's a access that you don't want to miss because it really makes a difference for people.
And I'll say this about tailbone pain. You're probably one of the only providers that can help them with tailbone pain.
Yes.
Telling you, any other PT too, like does not have that skill set for specific tailbone pain. You tell any other PT, ortho PT, whatever, they're going to crash out. And if they hear tailbone pain, they're going to crash out and give them a waffle cushion as I'm saying, just trashing PTs. That's not true. Other PTs I'm sure are helping, but pelvic health PTs, tailbone pain, we just have this extra skill set to like really see what is happening at the tailbone.
Mm-hmm. Absolutely.
Also having them point to their tailbone because not everyone knows where their tailbone is.
Ooh, good point.
Sometimes it's their sacrum. Mm-hmm. Okay. Wow. I just opened my phone. It was just these hot selfies of me with my new hair.
That's really good.
So
yeah. Selfie break.
Okay.
At least show them one of them.
I will post it on my Instagram. Okay. I feel like it'd be like really iconic just to kind of post like a really like chill unedited selfie.
Yeah.
Like not like bougied up, but just like a chill one.
100%.
Like this one. Beep.
Yep.
Okay.
Okay.
So jumping back into treatment strategies.
Okay. Can I talk about this?
Yes.
Okay. So I want to talk about the nervous system because when you think about, I have changed my billing and I will justify this 10 times over. All of my manual therapies that I do is neuro reeducation. That is because I am working on the patient's nervous system. I'm not going in and touching a muscle and saying, I am physically lengthening this tissue. That's not how it works. We don't really do that in the body. Muscles relax when they feel safe and your central nervous system has time to adapt to a stimulus. If you hold a static stretch for 2 minutes, the reason you can get deeper into that stretch is because your central nervous system has detected a lack of threat and it has decided to relax into the stretch. So we know this science of the nervous system feeling safer to relax a muscle. So when we're internal in a pelvic floor and we're doing an assessment and we find a trigger point, which is just a painful spot that can be referred in the pelvic floor, out of the pelvic floor, it could mimic the patient's pain pattern. It could just be painful on its own and they had no idea it was there. That's what we call a latent trigger point. If it's an active trigger point, it's going to be something they're aware of. That pain is something they've been experiencing. So we're releasing trigger points, and we're working on the central nervous system, and we can work on tight muscles. They are not always the same, but often they are combined. So when we're doing this, I will always hold pressure, and I will start a little bit softer, a tolerable level with the patient, and then after a minute or so, almost always 9 times out of 10, they will say, oh, I don't really feel that anymore. And we can add pressure and start to release it a little bit more. Sometimes if it's a really bad trigger point, I am on that spot for like 5 minutes at a time, just releasing one trigger point. So I love working on the nervous system. I always have my patients do deep belly breaths, something calming during this. I can distract them with a story if they want. If they want to tell me a story, fine, but I try to limit how much they're like talking rapidly because I want them to be able to breathe into it. You can feel the pelvic floor lengthening with the diaphragmatic breath, and that usually gets better throughout the session. I use this more than any active massage in the pelvic floor ever. I will even use this for entry pain, like first layer, absolutely works there. I use the main time I'm actually moving my finger and like massaging an area is for like scar tissue or something if I'm working on something there, but often I'm also just holding pressure on that. And that's my main internal technique I would say I use for treatment.
Yeah.
I'll do that rectally, I'll do that vaginally, I'll do that wherever.
Love. To me, manual therapy is like, when I think of manual therapy, I'm thinking like P-ROM of shoulder, something like that. Like my patient is just chilling and I'm kind of like working on them.
Yeah.
But when I'm doing like internal work with patients, they're rarely just like passively laying there and just letting me stretch a muscle.
Yeah.
Like that actually never happens, if I'm being honest. Like some type of breathing coordination, cueing is going on where like I'm having them, I'm almost like an alive biofeedback tool, like trying to give them this information. Like there's a lot more going on than just like passive stretching for it to just be like manual therapy in my brain. That's where my brain goes. So another thing that I like to do, that I feel like a lot of people don't do because they're afraid to get, I don't want to say afraid to get weird, but like you're afraid to like get off, like don't just have your patient in like butterfly or like hook line the entire time. If you feel stuck, you can have them do figure 4. I'll have them do like figure 4 on each side, depending on the side I'm on. Maybe have them do like a trunk twist with like a figure 4. Maybe we're doing like a happy baby or something like that. Those like the playing around, or even just a knee chest, like a single knee chest, play around with your hip positioning, hip flexion, hip rotation, because we're working on some deep ass hip rotators. No pun intended.
Yeah.
And then with like rectal work, same thing with rectal work. My biggest one, I would say, you can steal from me when I do rectal work with people and sideline, is have them do open books. So like a trunk rotation, fully open up into like an open book and then take a big inhale. And I promise you do that with your patient, you're going to feel their pelvic floor relax more because it just increases more intra-abdominal pressure and it kind of like makes the pelvic floor relax a little bit more.
Yeah.
And then I'll give that like as an exercise for people to at home or something. Like so using like extra movements, and it doesn't have to be the same things I do, but like whatever like functional movements that make sense to your patient and assessing that. Like we know we have some people do like a standing assessment and treatment in that.
And I'll add like one that I love to use is the bent knee fallout. And I'll do that a lot when I'm releasing or like holding pressure on obturator internus. And you can feel the muscle activate. It's a good way to actually test that you're on the right muscle too. And you can have a patient resist you, do like a contract, relax kind of release with them. So they're a little more active with it. And they'll start to like notice that area a little bit more and become aware of it. And then you can really feel the effect of it.
Yeah, there's so much you can do with the OI. Like what Amanda said, the knee fallouts, you can have them hold against your hand for 10 seconds, an isometric hold while you're palpating an OI, and then have them relax and then do that. You can do that for like exercises. You can have them do literally so many other exercises. You can have bridges. You can have them do hip adductions with like a ball or like a pillow squeeze, like while you're palpating internally, giving feedback or helping to like release a muscle after a movement, whatever it is. You can, I mean, that's like a lot of my heavy hitters, I would say.
Yeah. And I would say the gist of what we're getting at too, the biggest mistake I see PTs make, and when I want to like mentor and coach them more is when they're not spending enough time on one area internally. So we're not saying you have to be sitting there doing nothing for 5 minutes, like exactly what Hannah said. You can have them move and you can still be working on the same muscle that whole time. That's like doing 3 different exercises in the gym for one muscle group. Like how cool is that you get to do that internally and you don't have to just guess and do the guesswork outside of that. So the benefit of being able to get your patient moving, breathing, coordinating, doing whatever while you're helping them feel less pain, feel less tension in their pelvic floor is a huge asset that we have that other therapists do not have.
Yeah. Yeah, dude, it's crazy because you can do this all like passively. You can add in the breathing coordination. Now you can add in pelvic floor coordination. You can add in the Kegel with all of that. I'm like spending some time in that dang room at this point.
Yeah.
I'm doing so much in there versus just like a stretch. You know? So get creative and play around with what makes sense to you and for your patients, because these are techniques that we can use for stretching, relaxing the pelvic floor, but also strengthening, working on coordination and things like that. And there's plenty more that we're doing, but like it's hard when we don't have a specific patient case, for example, because every patient is so unique and may have many different comorbidities or things going on as well.
Yeah.
Like you can do some cupping on the abdomen and leave cups on while you do internal. You can move cups around while also doing internal work. Or even just like working, I don't know. Yeah. So many things.
There's so many things. And all of this could be progressive too. Like you might use something more passive at the beginning and then make it more active as you go. And that's your way of progressively overloading your internal treatment. There's progressions through all of it, and you're going to start with where you're going to meet your patient where they're at, and you're going to work with them and see what makes sense. This is probably an overwhelming amount of information for someone that wants mentorship.
I was going to say one other thing I'll say maybe is you can have patients bring their dilators in if they're really bad with their care. They can pop in a dilator while you step out, and then we're going to do abdominal work or like something like that, and then you can take the dilator if you don't want to do internal work, for example.
Yeah.
So those are other options where you can get a little bit creative out of just like the typical, okay, I'm going to do my perf assessment, I'm going to do strength, and then maybe I'll stretch the pelvic floor a little bit. Like that, we're just giving you limitless possibilities.
Yes.
And we didn't even touch on pregnancy postpartum stuff,
we didn't.
Which we don't have time for today.
We don't have time for today, but we do internal through all trimesters of pregnancy and postpartum after they're cleared for internal. But we also do stuff before then. And we could make a whole nother episode about that.
Yeah, just pregnancy postpartum stuff is just like a whole nother ball game of what we're doing with internal treatment. Like we said in the last episode, that's one of the most important things I think I do for my pregnant peeps.
Yeah. My biggest takeaway for the person asking this question is do not shy away from internal. I think start with where you're comfortable, because you as a clinician over the next couple years of being a pelvic floor PT are going to take in so much information and so much continuing ed, and the only way it's going to feel comfortable in your body is if you are doing repetitions and repetitions. So I would say if you're wanting to value internal treatment with your patients, don't shy away from it. Get comfortable having those conversations. Start with, your vaginal work. If that's where you are, I don't know how many levels you've taken, but then try to progress and get really solid with that rectal assessment. And you're going to see how much more confident it makes you as a clinician, because your diagnostic skills are going to get so much better when you really nail all of those different assessments.
Agreed.
Yeah.
Whoa. We're so smart.
We kind of are, right?
We kind of are, right?
I mean, sometimes we talk and I'm like, wow, we know some shit.
Sometimes I start talking and I'm like, oh my God, I'm like so hot and cool. And I have red hair and I look like a sexy Jessica Day.
I'm excited to get my hair redone because my roots are getting a little frizzy from all the matting.
Oh my God, yes.
Yeah.
Well, I think it's time to eat some pasta, eh?
Let's eat some pasta. All right, pelvic freaks. It's been a lovely freaking summer. We're going to see you again before summer officially ends, but I don't know. End of September just feels like fall. So this is really it for us.
We'll see you in September.
Bye, pelvic freaks.
Bye, pelvic freaks.